I think geriatricians are a bit of a Cinderella specialty, which I think is a great shame because they are really one of the specialties that still manage patients holistically and manage almost the entirety of their care with some involvement from specialist providers. Oncology is still a little bit holistic in that respect as well, which is why I enjoy it so much. And I feel that the geriatricians have positioned themselves within the acute hospital setting, and actually maybe that's not the right place for them. I think there's lots of arguments to say perhaps geriatricians are the people that can get people out of hospital who don't have medical needs and just have social needs, but I'm not sure that that's their job really. That's more of a social services type job, and my view is that if a patient doesn't require medical input, then actually it's dangerous to keep them on a medical ward. Other doctors will come along and do all sorts of tests and find things that are wrong, which quite often don't mean anything very much to an older patient who may have many other much more important problems than perhaps a low potassium, and if you eat a couple more bananas you'll probably be fine. So I think moving them out of a very medical setting into an intermediate care setting, so actually setting up intermediate care units within acute hospitals where once patients are medically fit they're moved to a nursing home type setting but within the hospital roof, should ease the burden on the sort of medical responsibility, but that setting could then be overseen by a community geriatrician, and that's the community geriatricians link in with the acute hospital. There are some pilot projects which Macmillan have supported in various trusts, but they have supported geriatricians within the acute setting to do that, and I would very much like to look at that model and use that as one of the models to actually assess, I suppose, in terms of outcomes, how many of your frail geriatric population required admissions, and then perhaps look at that with a population who hasn't got such a pilot study. So you could model how many of the acute geriatric frail oncology patients, for example, required acute admissions during a 6-month phase of oncology treatment and compare the two. You could then also model how a community geriatrician might pick some of those patients up by both referrals from the oncology service but also referrals from primary care because they're based in the community, and hence actually again prevent and minimise some of the admissions to acute whilst they're undergoing certain treatments. So I think you'd use modelling to try and look at the various different scenarios and come out with the one that actually helps the population at risk the most and allows you to deliver the most effective, safest treatment.